Hey everybody, thanks for tuning in to Module 6 on Ischemia, part of our EKG Fundamentals series. Learning objectives for this module, eventually you're going to be able to understand how EKG findings can be used to predict or diagnose ischemia of the heart. We're going to be able to recognize common EKG features associated with ischemia. And finally, you're going to be able to recognize how EKG features can help localize ischemia. Let's go ahead and review the normal circulation through the heart. The aorta gives rise to the right coronary artery and the left coronary artery. The right coronary artery goes on and feeds blood to the inferior portion of the heart, and in most individuals, the posterior portion of the heart. This is because in most individuals, about 70 to 80% of individuals, the posterior descending artery comes off of the right coronary artery, as opposed to the left circumflex artery in a small subset of individuals. The left coronary artery goes on and branches into the left anterior descending artery, or the LAD, which feeds the anterior portion of the heart, as well as the left circumflex artery, which feeds the lateral portion of the heart. And again, in a small subset of individuals, the posterior portion of the heart as well, through the PDA. So you can imagine if we had ischemic disease in any of these arteries, we would have EKG findings showing changes associated with that specific portion of the heart. And I wrote that here. Ischemic disease is seen in leads reflecting the part of the heart affected. For example, if we had occlusion of the right coronary artery, we would expect the inferior leads to show changes. The inferior ones you may remember include 2, 3, and AVF. Because remember, these three leads are looking up at the heart, looking at the bottom, the inferior portion of the heart. If we're looking at occlusion of the LAD, or the left anterior descending artery, we would expect changes to the anterior leads, which generally include V3 and V4, but can also include V2 and V5. Remember that these leads are placed on a spectrum around the chest. If we had disease of the left circumflex artery, we would expect changes to the lateral leads, which include 1, AVL, and V6, and maybe even V5. If we had disease of the left coronary artery, we would expect EKG changes everywhere from the septal leads to the anterior leads to the lateral leads, which is everywhere from V1 to V6. This is just another way to think about how specific leads reflect specific parts of the heart. So which leads reflect the inferior portion of the heart? These are 2, 3, and AVF, because these are the leads that are looking at the inferior, or the bottom of the heart. What are the leads looking at the lateral or very left side of the heart? These include 1, AVL, V5, and V6. These are all the lateral leads. What are the leads reflecting the anterior portion of the heart? That's going to be V3 and V4. These are the anterior leads. And then the leads reflecting the septum of the heart are V1 and V2. So these are the septal leads. Remember that all of these precordial leads are on a spectrum, so you can have some overlap when distinguishing septal, anterior, and lateral leads. And we'll get some practice with this in the following slides. Now let's discuss some of the EKG changes you would expect with ischemia of the heart. Shown here is the classic progression of EKG changes we see with ST elevation myocardial infarctions. However, I do want to emphasize that we do not always see this pattern in its entirety. We may see some of these phases being skipped around, or progressing in a different order. But what's important is keeping in mind the EKG changes we would expect to see with acute ischemia of the heart. The first thing we can see is T-wave peakening. So these are T waves that are pretty peaked. Sometimes it can be hard to identify what a peak T wave is. The general rule of thumb is if you step on a T wave with your toe and it ends up hurting you, then it's more likely a peaked T wave. We can also see T-wave inversions, and usually these are more obvious than peaked T-waves. We can see ST elevations. And then finally, we can see pathological Q waves. Keep in mind that smaller Q waves can be seen in EKGs that are normal. Usually lead 3 has a normal Q wave that can be seen. Pathological Q waves are usually deeper and are seen in leads contiguous with a specific coronary artery or specific region of the heart. On that note, I want to remind you that we would expect to see all of these changes in contiguous leads reflecting specific regions of the heart. This is important because changes such as T-wave peakening and T-wave inversions can be nonspecific and can be seen in other conditions as well. However, it would be more concerning for ischemia if we saw these changes in contiguous leads, or leads representing a specific region of the heart. There is one more very important EKG change not shown here that we can see with ischemia of the heart, and this is an ST depression. We've seen ST depressions in previous modules, but it looks something like this, with the ST segment being lower than the TP segment. ST depressions are seen in non-ST elevation MIs, which have a slightly different pathophysiology than ST elevation MIs. However, even though it's not the intention or the goals of this video, I do encourage you guys to read up on the difference between STEMIs as well as NSTEMIs in terms of pathophysiology. Okay, take a moment and try to identify any ischemic changes in this specific EKG. Let's start out by looking for T-wave inversions or T-wave peakening. I don't see any peaked T-waves, but I definitely do see some T-wave inversions, specifically in leads 1, in AVR, in AVL, in V5, and V6. Again, there are no peaked T-waves. I don't see any ST elevations or depressions anywhere either. I don't see any pathologic Q waves. There's a tiny Q wave in AVL, but because it's small and it's not present in contiguous leads, I'm not concerned about that Q wave. However, what are present in contiguous leads are these T-wave inversions. These T-wave inversions are all present in the lateral leads, reflecting the lateral portion of the heart. This EKG, while it's not diagnostic, it is suggestive of disease of the left circumflex because it involves the lateral wall of the heart. Take a moment and try this one out. Let's look for any T-wave changes. I don't see any peaked T-waves, but I do see a T-wave inversion in AVR. I want you guys to remember that T-wave inversions in AVR are completely normal findings, and you will see this very frequently in EKG tracings. So we're not very concerned about this. What about ST changes? Well, there are definitely ST depressions in V2, V3, V4, V5, and even V6. And also, if you look very closely, we see a small ST depression in lead 1 as well. So this is reflecting the anterior and the lateral portions of the heart. Finally, notice that there are no large pathologic Q waves in any of these leads. Ultimately, this is not diagnostic, but suggestive of disease of the LAD for sure, and maybe even the left circumflex artery. I do want to note that ST depressions seen in the precordial leads in this fashion can be seen in other conditions as well, such as left ventricular hypertrophy or left bundle branch blocks. We'll talk more about those in our following videos on conduction abnormalities and structural abnormalities. Pause the video and give this one a try. Alright, let's look at the T-waves. Are there any T-wave inversions or peakening? The answer is yes, there are definitely peaked T-waves in V2, V3, V4, maybe even in V5, but definitely in V2, V3, and V4. I don't see any concerning T-wave inversions. However, there are ST changes, specifically ST depressions that we also see in V2. You see a small one there. V3, V4, V5, and a little bit in V6 as well. Finally, there are no contiguous pathologic Q waves present in this EKG tracing. Again, this is reflective of definitely anterior but also a little bit of a lateral disease, most likely involving the LAD. Pause the video and give this one a try. Okay, let's start out by talking about the ST segments. Do we see any ST elevations? The answer is yes. There's definitely an ST elevation in V1, V2, V3, V4, V5, maybe a little bit in V6, for sure a little bit in lead 1, as well as AVL. You may have also noticed the subtle ST depressions in AVR and lead 3. Let's talk about the ST elevations first. The ST elevations are present in the septal, anterior, and lateral leads. Essentially, it's involving everything on the left side of the heart. The likely culprit here might be a left coronary artery or left main coronary artery occlusion. So why do we have ST depressions in AVR and 3? This brings up the idea of reciprocal changes. When we have EKG findings suggestive of ischemia in a certain part of the heart, occasionally we can see reciprocal changes in opposing parts of the heart. For example, in this EKG, we have a lot of ST elevations reflected in the anterior and lateral or the left leads of the heart. We would expect reciprocal changes or ST depressions in leads reflecting the right side of the heart, the opposing side of the heart. If you think back to our lecture on leads, you'll remember that AVR looks at the right part of the heart, and lead 3, which definitely looks at the inferior part of the heart, also looks at the right part of the heart a little bit too. And for this reason, these specific leads on this EKG tracing show ST depressions, which are reciprocal changes. Finally, I do want to note that there are deep Q waves in V2, V3, and V4. You may think V1 has a Q wave, but it's actually an RS complex. You'll see the little R wave before the S wave. Again, this is suggestive of disease involving the anterior portion of the heart. Pause the video and give this one a try. What do we see here? So there are definitely ST elevations in leads 2, in 3, and in AVF. There are ST depressions in leads 1, in V2, V3, and V4. Along with the ST elevations are T-wave peakening. It's a little bit harder to tell because the ST lifts up the initial part of the T-wave, but they are peaked in leads 2, 3, and AVF. And then we have T-wave inversions in AVL, V2, V3, and V4. What is going on here? So we have ST elevations involving 2, 3, and AVF. These are all inferior leads. They're reflecting the inferior view or the inferior portion of the heart. We also have reciprocal changes involving other parts of the heart, most prominently in the anterior portion of the heart. This is a classic EKG finding of inferior wall myocardial infarction, most likely a result of occlusion of the right coronary artery. Pause the video and give this one a try. Okay, I'll be a lot quicker with this one since we got a lot of practice already. I do see ST elevations in 1, AVL, and everywhere from V2 down to V6. There are also peaked T waves from everywhere from V2 to V6. Finally, we see pathologic Q waves from V2 all the way to V6. Altogether, these reflect the anterior and the lateral portions of the heart. Again, concerning for an LAD occlusion, but may also involve the left circumflex artery as well. Here are some of the takeaways. We talked a lot about ischemia in this video. Keep in mind that the EKG can aid in the diagnosis of ischemic heart disease. We can see T-wave changes such as peakening, depression, meaning flattening, and inversions. We can see ST changes, elevations or depressions. We can see pathologic Q waves. And keep in mind that these changes generally occur in a contiguous pattern. I do want to note that there are other EKG changes that are concerning for ischemia and infarction that might be worth knowing. These include the Wellen syndrome and De Winter T waves. Once you establish a basic understanding of EKGs, it might be worth reading up on these. That's it for this video. I'll see you guys on the next one.